Welcome back, everyone, to the Zero Suicide webinar series. Today's webinar, the final in a 6-week series, is Follow-Up and Care Coordination. This event is brought to you by the Center for Health and Learning and the Vermont Suicide Prevention Center under funding from the Vermont Department of Health. I'm Zan Lewis, your moderator. Given that this is our last webinar, I will chat our reminders into the chat box. Please have a look and direct message Zan Lewis to let me know of any questions. Today, Joellen Tirallo, Executive Director of the Center for Health and Learning and Director of the Vermont Suicide Prevention Center, is presenting. I'll hand it over to you, Joellen.
Thank you, Zan. As we're building out this work as we move along, today's webinar will review what we have learned from research and work done nationally. Integration with approaches to follow-up and care coordination in Vermont healthcare settings is just beginning. We will explore approaches to this work that are occurring in Vermont settings in a full session at the Zero Suicide Skills Institute scheduled for May 7th and June 6th. Templates and other resources will be put up on the website following the Skills Institute for access and adaptation to your unique settings. There is more information on this later in the webinar. The webinar is brought to you by the Vermont Suicide Prevention Center, a public-private partnership aimed at providing cross-disciplinary and cross-sector access to best practices for suicide prevention under funding from the Department of Mental Health, foundations, and supporting donors. The Vermont Suicide Prevention Center is under advisement of the Vermont Suicide Prevention Coalition, which draws its membership statewide from organizations and individuals concerned about suicide. The coalition meets quarterly. If you would like to be on the mailing list for coalition meetings, please contact info@healthandlearning.org. The Vermont Suicide Prevention Coalition developed the Vermont Suicide Prevention Platform as a guidance document for Vermont in 2015. There are 11 goals in the platform, and it uses an ecological approach based on the National Strategy for Suicide Prevention. This webinar series supports goal number 7, promote suicide prevention, screening, intervention, and treatment as core components of healthcare services with effective clinical and professional practices. These are the metrics that Vermont has committed to in the all-payer model. Goal number 2 of the all-payer model specifies reducing suicide deaths. Reaching this goal will necessitate adoption of principles and practices of a suicide-safe pathway to care embedded in the zero suicide model. We have previously reviewed epidemiological trends of data in Vermont and will not be addressing that today. Check back with webinar number 1 and 2 for that information. Today, participants will learn about research on practices and practical approaches to follow-up and caring contact in the national literature. You'll be able to describe 2 or more approaches to follow-up and care coordination used in healthcare settings to address suicidality specifically, and consider the next steps for adoption in your organization. What questions do you have for us before we begin? While you will be on mute during the presentation, we encourage you to type your questions into the questions box right now and at any time throughout the webinar. Within 1 week of the webinar, the slides and a recording will be available at the Vermont Suicide Prevention Center website on the Zero Suicide page through June 30th, 2019. Zan, do we have any questions?
We do not, Joellen.
Okay. We're going to ask you to participate in a poll as we begin today. There will be 2 questions that will pop up on your screen. The first question is, has your organization instituted protocols specific to follow-up and/or care coordination for patients who are suicidal? Yes or no? And 2, how satisfied are you with your current state and approach to follow-up and care coordination of patients at risk of suicide? Very satisfied, satisfied, neutral, slightly satisfied, or not satisfied?
Great, thanks, Joellen. I'm about to launch the poll, so you'll see it pop up on your screen for the first question. And I'll give you a little bit of time to answer, and then we'll share the results. Okay, I'm going to close the poll in about 5 seconds. Great, thank you for your participation. So out of respondents in response to the question, has your organization instituted protocols specific to follow-up and or care coordination for patients who are suicidal? 57% replied yes, and 43% replied no. And I'm now going to launch the second question. You should see it pop up on your screen. And as a reminder, the question is, how satisfied are you with your organization's approach to follow-up and care coordination of patients at risk of suicide? And so we'll keep it open for about 10 more seconds. All right, I'm going to close the poll. Thank you again for participating. So we had a variety of answers to this question. 0% of you replied very satisfied with your organization's approach. 17% replied satisfied. 0% replied neutral. Another 17% replied slightly satisfied, and 67% of respondents replied not satisfied.
Thank you so much for reviewing those results, Zan. It looks like we're generally on the early end of an adoption process around this, and we have a lot to learn from one another. We fully expect that you will examine your already existing systems for follow-up care coordination and caring contact, and take what you learned today and apply it to them. Again, we want to remember the language we use to communicate about suicide. It is important. Please use the phrases on the left and avoid those on the right. This takes practice, and we encourage you to remind each other about the use of sensitive language as you adopt suicide-safe care practices. Once again, the conversation about follow-up, caring contacts, and care coordination today is embedded in a zero suicide approach. Follow-up, care coordination, and caring contacts relate to all three facets of the zero suicide model. Follow-up and care coordination, caring contacts are deeply related to a commitment to continuity of care for a patient and the notion that there is shared service responsibility for any patient accessing the healthcare system. In the case of follow-up and care coordination, this involves special attention to referrals between providers and transitions to and from home, treatment settings, school, and/or the workplace. Follow-up and care coordination is enhanced through policies and procedures that are specific and clear to everybody and to which everyone is oriented and prepared to carry out. And they are part of a set of evidence-based practices implemented along the continuum of care from identification through treatment and return to home or another setting where a patient spends time and may need support. This graphic is designed to underscore how critical it is to have strong linkages, care coordination, and communication mechanisms in place to ensure that previous clinical assessments and efforts between providers and services are part of a comprehensive system of care. These issues are assessed in the Zero Suicide Organizational Self-Assessment. Continuity of care strategies are an important part of Zero Suicide, a systems quality improvement framework that has many components with evidence of effectiveness in reducing suicide attempts and deaths. The data assures us that when all the zero suicide strategies are practiced in combination and through a lens of continuous quality improvement, that suicide deaths and attempt rates in health and behavioral healthcare systems are significantly reduced. This is Vermont's graphic for showing the zero suicide system across a continuum of care and specifies the evidence-based practices we have chosen to use for each level of the system. You will notice that between each level of service intervention in this system, there is a gray banner that specifies care coordination, follow-up, and ongoing caring contact with the patient. Critical to a suicide-safe pathway for patients navigating the system is care coordination and follow-up. Simplifying this down, it translates to ongoing caring contact with a patient at risk. Even simple and inexpensive approaches to follow-up show reduction in suicide. Today, we will consider caring contact within the zero suicide model, some of the underlying theory of caring contacts, research that has been done on this, the role of the use of technology, email, text messaging, and consider clinical, legal, and technical aspects. In July 2014, a seminal report related to recovery was published by the National Action Alliance for Suicide Prevention, which included, among many other things, recommendations for addressing care coordination and follow-up for people who experience suicidality. Zero Suicide defines caring contact as persons with suicide risk get personal contact during care and care transitions with method and timing appropriate to their risk, needs, and preferences. Persons with suicide risk get timely and assured transitions in care, and providers ensure that the transition is completed. I would like to take a moment to emphasize how critical connectedness is. It is a critical factor for patient engagement, adherence to protocol, and ability to navigate a patient's way through a pathway of care towards recovery from suicidal ideation or attempt. We define connectedness as the degree to which a person or group is socially close, interrelated, or shares resources with other persons or groups, occurs within and between multiple levels of the social ecology, the individual themselves and their families, schools, community organizations, their neighborhoods, cultural groups, healthcare, and society as a whole. Connectedness among community organizations and social institutions at a time of crisis is very important. They represent the formal relationships between support services and referring organizations. They help ensure that services are delivered and promote a client's well-being, as in the case of the primary care system and the mental health system working closely together. Follow-up, caring contact, and care coordination reinforce connectedness as a protective factor in the system of care, and it turns out that while they are low-tech interventions, they increase positive patient outcomes. Dr. David Luxton at the University of Washington School of Medicine in Seattle has been a pioneer and researcher around the importance of caring contact. He has worked closely with the military on conducting a randomized control trial. We will discuss the results of this and provide examples and templates at the Skills Institute later this spring. He conducted a meta-analysis of caring contact studies. In 2015, he was the principal investigator for research with the Department of Defense in a caring contact study, Caring Letters for Military Suicide Prevention, a randomized controlled trial. Military Operational Medicine Research Program funded 6 site randomized controlled trials in Washington, Germany, Hawaii, San Diego, California, and New York. One of the significant caring contacts intervention were caring letters. Caring letters is a suicide prevention intervention that entails the sending of brief messages that espouse caring concern to patients following discharge from treatment. The original Caring Letters study was conducted by Motto and Bostrom in the early 2000s. Here is an example of a simple, non-demanding expression of care. Dear patient, it has been some time since you were here at the hospital, and we hope things are going well for you. If you wish to drop us a note, we would be glad to hear from you. With multiple contacts, the theory is that this may contribute to a sense of belongingness via a caring connection. It also serves to remind the patient of treatment availability and may provide additional incentives for the patient to seek help. And it helps patients feel better about treatment and therefore motivate them to adhere to treatment. Non-demand caring contact has strong evidence in the literature. In this study, letters were sent monthly, decreasing to quarterly for 5 years. The history of this is that the researcher, Jerome Motto, was fighting in Europe during World War II. Someone kept sending him letters, and he found the letters very helpful. Later, he was working in a psychiatric unit in San Francisco, and he decided to try caring contact letters with patients who were discharged. He put together a study to track where people were 30 days post-discharge, and he randomly assigned patients to 2 groups, one receiving letters and the other not. The letters basically said that they were thinking about the patient and offered to be in touch if it would be helpful. He analyzed who had died and not died over the subsequent 5 years, and the data showed that there was a significant difference among those who had received the letters. People have been replicating this with different locations and groups. The approach is called non-demanding, without implicit or explicit parameters, voluntary or involuntary hospitalization, screening, etc. No strings attached. His belief is that there are too many things we ask of people to get care, hoops to jump through, time, location, providers, and these are barriers. The reach out is very simple. Thinking about you. It's been a while. We're here if you need us. The cards had a puppy dog on them. Dr. Nancy Comtois, University of Washington, is also doing research on this, and she can be heard online. In particular, she's focusing on the cultural considerations for using this approach with Native populations and active duty soldiers and Marines. This is another study that was comprised of a randomized control study in 5 countries, comparing the group of previous suicide attempters who received psychoeducation and a series of personalized follow-up contact, either by telephone or in person, versus a non-contact control group. The individuals who received the personalized follow-up intervention were less likely to later die by suicide than those in the control group. We'll talk about other caring contact studies. The outcomes, self-directed violence or suicide ideation reduction, were the objectives. Postcards, postal letters, SMS texting, email, and mixed modality reaching out, in person, phone, etc. David Luxton currently has a 5-year randomized control study where he is working with caring emails versus no emails with a population of 2,300 patients. The method is psychiatric inpatients are interviewed while on unit, and then the randomized receive emails for 2 years, sent in this schedule. Here is an example of a sample caring email. Dear patient, we appreciated the opportunity to get to know you while you were at the hospital and we hope things are going well for you. We remember how you said that you enjoy hiking around the South Puget Sound. With the return of the summer weather, we hope you're getting a chance to get out there and explore some new trails. Anyway, we just wanted to send a quick email to let you know we're thinking about you and wishing you well. If you wish to drop us a note, we would be glad to hear from you. Sincerely, the provider. Please note that the following resources are always available to you, and the letters would provide a list of resources. Please know that I make every attempt to respond to my emails each business day. If for some reason you need immediate assistance, please reach out to the resources listed above. Also, you should refrain from replying with any sensitive personally identifiable material or confidential information, to include medical information over the internet. If you choose to send such information via email, please know you are doing so at your own risk. If you will be changing your contact information, email address, phone number, postal address, feel free to let us know so that we can stay in contact with you. In this randomized control trial method, as we discussed, emails were sent over a 2-year period with a follow-up survey sent at 2 years. The outcomes showed the following: suicide mortality rates, self-inflicted injuries, time to suicide event, treatment utilization, assessment of risk factors, and attitudes about treatment caring emails. These were the issues that it seemed most important to address following the results. Best practices need to consider the procedures in place for addressing emergencies and crises when they arrive, safety planning, to consider the impact on the patient when sending the final contact, and to consider legal regulatory requirements when using technology, such as data security. Given the intention of the outcomes, the study found the following caring contact benefits. Caring contacts were found to be one of the only psychological interventions shown to reduce the rate of suicide deaths. No risk to patient, causes no harm. Potential long-term suicide risk reduction, and simple and inexpensive intervention, which can easily be augmented with other targeted interventions, such as safety planning approaches, post-admission cognitive therapy, collaborative assessment and management of suicidality, etc. The benefits of caring contact is that it reaches high-risk patients that do not stay in care and can provide direct route to care and resources. It can use existing staff and resources to implement, and again, it can easily augment other targeted interventions. We do want to emphasize the risk of post-hospitalization suicide. The research has shown, and the zero suicide model emphasizes, that hospitalization is often not the best option. This is derived from input from those with lived experience reporting hospitalization can be re-traumatizing. Traditionally, hospitalization often does not result in treatment of suicidality-specific issues. It can provide a place of safety and respite for a very short time while the individual or family is in crisis. However, it also results in a well-established time of risk. With a high-risk population, suicidality is not generally effectively treated while in care, with brief inpatient stays that are not found to be high risk at the time of and the patient is not found to be high risk at the time of discharge. There is often a lack of care transition and actual discontinuity of care. And the patient returns to the same environment with the same kinds of conditions and potentially social isolation and lack of support. This is the summary of research from the following references. I'm now going to turn my attention to the clinical elements of follow-up and caring contacts and provide some concrete examples of different types of caring contact. Supportive contacts are provided in this model at breaks in care where there may be missed appointments or missed refills, at times of stress, or after acute care, the emergency department, inpatient stays, or crisis care. We will now review some of the kinds of follow-up and caring contact reviewed in this next resource. This is an excellent resource created in Utah to guide transition planning. Transitions in care include discharge from the hospital inpatient emergency department, referral after suicide risk assessment in a primary care or crisis setting, or any time when a patient at risk of suicide is between care providers. These gaps in care are times of heightened risk, especially after discharge from inpatient care. A 2017 systematic review found that the post-discharge population has a rate of suicide that is 100 times higher than the general global population, specifically in the first 3 months after discharge. Chung, 2017. Suicide rates generally peak in the first week after discharge from a psychiatric inpatient care, from another study in 2005. Strategies to promote continuity of care are needed to address these periods of heightened risk, particularly for individuals that are difficult to engage in treatment, such as the underinsured, low socioeconomic status individuals, and males. Many individuals undergoing care transitions experience a complete lack of support during high-risk transitions in care or when ongoing services are interrupted. For example, an appointment is missed. These gaps in care are unacceptable for high-risk individuals, and changes in systems and practices are urgently needed to address them. This resource includes a section on creating an office protocol for transitions in care with examples of all the communications we are about to discuss. Follows is a review of the types of transition plans included in this guide. The first is called stepped care. Stepped care refers to a continuum of treatment intensity based on the needs of the individual. Rather than relying only on traditional methods of outpatient care and emergency departments only, stepped care offers a broader range of care, including intensive outpatient, mobile crisis supports, crisis stabilization units, peer support, and other creative solutions to meet the needs of individuals in the least restrictive setting possible. For each of these types of caring contact and transition tools, this review provides examples of good ways of carrying them out, better ways, and best ways. The best generally includes the good and better ways, in addition to another step. So in the case of stepped care, and I'm not going to review these for each type of caring contact, but I will for this one so you get a feel for it. The good model of stepped care is to provide a 24-hour access to crisis resources over the phone, texting, and utilizing the ED, emergency department, for acute or imminent suicide risk. A better approach is all of those, as well as providing intensive outpatient options, crisis stabilization units, walk-in crisis centers, and/or mobile crisis. Best of all is having the above supports and providing peer support, linked electronic health records, and/or an air traffic control center to deploy mobile crisis and monitor availability of inpatient bed availability in real time. Another form of caring contact are MOUs and MOAs. These are not with the patient themselves, but are with partner organizations. For example, with a local hospital, outlining the role that each entity has for screening, assessment, safety planning, discharge planning, and follow-up to allow multiple agencies to coordinate care. MOUs are critical to assist in providing clear arrangements for information sharing, including establishing procedures for access to relevant assessment information and policies around warm handoffs and rapid referrals. The best MOUs or contracts provide rapid referral for clinical mental health services with a policy in place around care coordination, which includes warm handoffs, rapid referrals, stepped care options, and includes defined information sharing, comprehensive evidence-based suicide risk assessment, safety plan, and a discharge plan. Records and assessment information records and assessment information are shared directly through a linked electronic health record, if possible. Warm handoffs provide an introduction to the new care provider before the care transition to build a relationship with the referred provider or organization and to decrease no-shows. This contact could include care coordination dialogue between the current provider to the referred provider and care navigation support individual to referred provider. The referring provider may arrange an introduction with the new provider in person, by phone, or through telehealth technology. Alternatively, the referring provider may make a linkage with another staff within the referral organization, such as a peer provider or continuity of care staff, who is responsible for maintaining care throughout the transition time for the person at risk. Organizations do their best to ensure that individuals have rapid access to initial outpatient appointments following discharge and referral. Appointment scheduling is an important type of follow-up and care transition. Providers supporting care transitions, such as crisis staff, should have the capacity to schedule follow-up appointments while still engaged with the individual at risk. Consider the use of telebehavioral health when appointments are not readily available. The sooner the follow-up appointment can be scheduled, the better, and the ideal is to maintain consistent contact with the patient during the care transition. This speaks about the importance of provider communication in care transition. The care transition should be supported through effective communication between the referring provider and the receiving provider. Providers should send documentation on the individual at risk prior to the scheduled appointment and follow up with a conversation between providers to share relevant information. Provider communication, including communication of patient discharge plans prior to the first appointment, may triple the odds of a patient engaging in outpatient behavioral health care. Care navigators, community health workers, and case management has been shown to be especially helpful in providing continuity across primary care and behavioral health systems and across hospital and outpatient settings. The care navigator can enhance these system relationships by serving as a liaison, improving communication across providers, and facilitating access to care. The use of motivational enhancement strategies may increase the effectiveness of care navigation and care coordination. They also provide support to the patient to increase engagement in care. Peer specialist supports. Organizations can engage internal or external peer specialists to assist individuals at risk in navigating behavioral health systems and provide support and encouragement during the transition period and possibly beyond. One study demonstrated that utilizing peer support organizations in the discharge process shortened the length of hospitalization, reduced the use of hospital and emergency department services over 12 months, and reduced the overall cost of care. the intervention was most beneficial for those individuals describing themselves as lonely. Engagement of support networks. This strategy includes involving supportive family or friends through education around the elevated risk period and inclusion in the discharge and transition planning. Persons in the individual support network can also be included in plans to reduce access to lethal means. Information should be shared regarding crisis services, the patient safety plan, community supports, and outpatient care. Caring contacts can be done by staff in any program that has provided acute care, that is, the emergency department, crisis setting, or inpatient programs, by outpatient programs that provide ongoing care during high-risk periods when an appointment is missed or treatment is discontinued, or by crisis centers that can conduct follow-up under contract with other services. These contacts are brief communications expressing care from a provider and could be delivered in person by phone, letter, or postcard, email, or text. Caring contacts follow a preset schedule and have ranged in studies from 1 to 24 contacts, with most lasting for up to 18 months. A review of the evidence supporting caring contacts found that various methods of supportive contacts can be effective. Examples of caring contacts can be found on the resources page of the Zero Suicide website, and we will point you to that in just a few moments. The best case in caring contacts is that a policy is in place to determine how long the caring contacts are given. For example, until the person is engaged in care, until the suicide risk is reduced by assessment, or for several months, years if neither of these conditions are met. Structured follow-up and monitoring may also be used for patients already engaged in care between outpatient appointments. Early adopters of the Zero Suicide model, which includes attention to follow-up care coordination and caring contacts, such as Centerstone, are showing positive results from implementing the principles and practices of Zero Suicide. Recently, there was discussion on the national listserv about this. In Columbus, Ohio, NetCare Access, a walk-in crisis center, sends follow-up cards to every client discharged home after a crisis episode. They send 8 cards throughout the year, 1 per month the first 8 months, then 1 card every other month for 4 more cards. With clients who discharge home from their crisis stabilization unit and their crisis residential unit, they also do follow-up calls linked with outpatient appointments. Telephone crisis hotline clinicians make these calls and send these cards. A health system in Connecticut has a behavioral health network made of 6 hospitals with at least 1 inpatient unit at each hospital. Every inpatient unit makes caring contact connection calls 24 business hours post-discharge. There is a script which is used during these calls for standard work and to manage the time spent on the calls. Various disciplines make the calls, including case managers and social workers. There is an online website focused on follow-up, followupmatters.suicidepreventionlifeline.org. Follow-up care saves lives and resources, and when connected with a crisis center for follow-up, individuals reported less stress and lower risk of suicide. Follow-up care allows hospitals and insurance companies to save money and redirect their resources to necessary visits. You may check this resource out online. The National Suicide Prevention Resource Center provides a full toolkit supporting the implementation of Zero Suicide. www.sprc.org, visiting the section of resources related to structured monitoring and follow-up care are found in the Transitions section. And the Vermont Suicide Prevention Center also provides online resources to support zero suicide implementation. www.vtspc.org. Go to the drop-down menu under Resources, click on Zero Suicide. Resources are available to support your implementation, including statewide gatekeeper trainings and zero suicide trainings that are upcoming. This webinar series will be online and the Skills Institute flyer will be distributed shortly. These are the predominant resources of help we're directing people to in Vermont. All of the resources we present are available for download on the Vermont Suicide Prevention Center website, including this Need Help card, which can be used as a poster in any setting. In summary, we have now had a discussion about follow-up and care coordination based on work already established in your care pathway is an important part of the zero suicide approach. And there are resources nationally available to assist you with this work. Thinking ahead to next steps for leadership implementation and getting started. The core elements for success in any change apply here. Leadership commitment and support, a dedicated team to champion the effort, taking time to plan your work and working your plan, and communicating with your stakeholders internal to your organization and with important external partners and stakeholders as well. Experience of early zero suicide adopters indicates that completing and discussing the organizational self-assessment is a good first step, and you will have the opportunity to work with other teams around the state and your own team under the advisement of National Consultant Dr. Michael Hogan at the Zero Suicide Skills Institute's first day on May 7th. Workforce assessment has helped pave the way for adopting zero suicide evidence-based practices and doing some initial shared training together. For example, committing to the Counseling About Lethal Means online training, which is 2 hours, has recently been redesigned, or inviting You Matter Gatekeeper training or ASSIST training or other national best practice program trainings. Participation of survivors keeps it all real and well advised. Here's a little bit of information about the Zero Suicide Skills Institute, which will be 2 days of workshops and team planning, time for zero suicide steering teams from healthcare settings to work together. On May 7th, the focus will be conducting the Zero Suicide Organizational Self-Assessment under the advisement of Dr. Michael Hogan of Hogan Health Associates, Dr. Thomas Delaney, University of Vermont, and the Vermont Zero Suicide Pilot Site representatives who have experience with early adoption. On June 6th, planning for workforce development and implementation of clinical elements of zero suicide, we will have workshops and presentations by Adam Lesser of the Columbia Lighthouse Project and Kevin Crowley from CAMSCare, who will do a deeper dive into using these tools and resources. And Vermont Zero Suicide Pilot Site representatives and healthcare providers who have experience in various facets of the elements of zero suicide will be working with these teams who attend. We hope you have found this webinar series helpful. Please stay online to participate in the evaluation of this webinar. You will also be receiving a brief evaluation to provide feedback on the webinar overall as an email with a link. This feedback is used for program improvement and future programming decisions and is very important for reporting to our funders and sponsors. To access these webinar recordings and slides, Access the vtspc.org/0-suicide-page/. And remember, as you think about best practices for taking care of others, remember self-care and take care of yourself. We thank you for the work you do and for attending today's webinar and this webinar series. We hope we'll be hearing more from you and see you at the Skills Institute in May and June. Please feel free to contact us at Vermont Suicide Prevention Center if you have questions, or the Department of Mental Health in Vermont that is funding this work. Please wait for the evaluation to pop up